feel like I need some elevator music in the background as people are hopping on, but it is 12:02 and I know we have a lot of, our panelists have a lot they want to cover. So I am going to go ahead and say we should get started here. Forgive my distraction as I'm managing multiple devices, but I am Madeline Wagner. For those of you who don't know, I am the program support assistant for the Center for Pharmacy Practice Innovation, and that is the organization hosting the seminar today. So thank you all for being here, audience and panelists. Dr. Patterson, I'm going to let you introduce yourself if that's okay, and then you can introduce our panelists.
Yeah, fantastic. Thanks so much. So my name is Dr. Julie Patterson. I'm assistant professor here at VCU School of Pharmacy, and I'm very excited to be moderating our session today about value assessment in practice and policy. Value assessment in healthcare means that we're evaluating the effectiveness of services and treatments. So how well do they actually work to improve patient outcomes while simultaneously evaluating the cost of those services. It's a dynamic area. It's highly relevant given our drive to improve patient-centered care with options that are both high value and affordable long-term. So that's why I'm especially excited to introduce to you two international experts in value assessment who are going to be discussing their perspectives on the current and future landscape of value assessment. So without further ado, let's go ahead and introduce our speakers. So we'll go alphabetical order here. Dr. Dalia Dawoud is a scientific advisor on the Science, Policy, and Research Program at the National Institute for Health and Care Excellence, or NICE, based out of London. She has a Ph.D. in Pharmaceutical Policy and Economics and a Master of Science in Economic Evaluation in Healthcare. She is the current chair for the International Society of Pharmacoeconomics and Outcomes Research's Biosimilar Special Interest Group and has long experience in clinical guidelines development and health technology assessment gained through working on NICE clinical guidelines as well as technology appraisals. Her research interests are focused on advanced methods of evidence synthesis and use in economic models and the use of real-world evidence to inform drug development and healthcare decision-making. Our second panelist today is Dr. Joey Mattingly. He simultaneously earned his Pharm.D and MBA from the University of Kentucky, after which he dove into pharmacy practice at the Kroger Company. He worked in management there for several years before transitioning to academia. He currently serves as an associate professor in the Department of Pharmacy Practice and Service at the University of Maryland School of Pharmacy, where he teaches business strategy to students in the professional program. He recently earned his Ph.D. in pharmaceutical health services research with a special focus in pharmacoeconomics. Dr. Mattingly's primary research interests include incorporating the patient voice into health economics and outcomes research. Through patient engagement, Dr. Mattingly hopes to improve methods for value assessment of new pharmaceuticals and to improve health outcomes by changing the structure and processes involved in patient care delivery. And as I mentioned, I will be moderating this session. So this is going to be an interactive Q&A session. We're going to be asking for our panelists' perspectives as we go through. And please, I would love to entertain questions at the end. And so as questions come up, you can be putting them in the chat, and Madeline will be kind of monitoring that there because I know they're very excited to engage with you all on this topic. So let's go ahead and dive right in. Our first question here is kind of a broad question, allowing you to speak a bit to the value assessment environment in both the US and in Europe. So Dr. Mattingly, I'm going to throw this first one to you first, since our speakers are probably more familiar with the healthcare landscape in the United States.
Great, thanks. And first, thank you all for letting us attend virtually. It's a great honor to work with the VCU team. Really had a great opportunity to get to know a lot of faculty at the school, and it's really a pleasure. I think post-COVID, I hope we get a chance to come down and do this type of lecture again in person one day. So in terms of the first question, thinking about value assessment and in the US, to be frank, it's not existent. The US does not have a formal value assessment that's conducted for a U.S. population level, similar to what we see in other countries that Dr. Dawoud is going to talk a little bit about. But with that said, don't be mistaken. Every private insurance company, as well as public funded Medicare, Medicaid, everyone who manages a population's health and managed care has to consider cost effectiveness and budget. And again, I know we have a diverse audience, and so there's probably different levels of like what everyone's familiar with in terms of the lingo. When we use phrases like cost effectiveness, again, we're talking about the cost of a product compared to the cost of another product, and the effectiveness of that product compared to another effectiveness to see which one is more efficient to use. And when we talk about budget, we're talking about, despite of what's cost effective, what can we afford? What can we afford for the population? So it's really important that we know that in the US, the value assessment is done, but it's under, you could say, like a black box. It's done independently, or it's done by companies differently. We saw recently that even CMS saw the writing on the wall with a new drug, aducanumab, for Alzheimer's disease. They saw the potential budget impact, and obviously other challenges with effectiveness, and whether or not they did not do a formal value assessment, published value assessment, or anything to that nature to make a decision. But CMS is going to limit how we use aducanumab. So to say that it's not done is also not accurate. So, but I want to be clear that we just don't formally do it as a government. We do have organizations such as the Institute for Clinical Effectiveness, I don't want to get it wrong, Clinical and Economics Review, ICER, the acronym ICER. Some of you may have seen their work. They are a value assessment framework that's built similar to other organizations in Europe, I think modeled after NICE and things like that. So we do have organizations in the US that are doing these things, but they are separate from the US government. They are independent entities.
Thank you so much. Dr. Dawoud, do you want to take it from there and kind of speak to the environment in Europe?
Yeah, sure. Thank you so much, Julie, for the introduction, and thanks again for the invitation. Really delighted to be joining Joy today on this panel and to join you all talking about this important topic. I'd imagine that I think it's gaining traction in the US, although as Joy explained, it's not that done on a national level. It has been ongoing discussion in Europe and has been used actually in informing decision making for quite some time now. And I'd reflect primarily both on Europe as in general and more specifically on the UK, where my background is and my current role is based. So generally in Europe, there are different value assessment frameworks that are currently used, and there has been for some time ongoing collaboration on a national between member states and the European Union on the level of health technology assessment, which is, I'd say, another term for assessing value of new intervention or health technologies specifically. So health technology assessment within Europe has started to gain momentum for some time now, over 10 years, with some attempts for international or regional collaboration in the establishment of the UNETA, or the European Network of Health Technology Assessment Agencies. And more recently, actually, this started to take even a higher level with the issuing of the HTA regulation, or the move towards having HTA regulation across Europe, although the cooperation in that is primarily focused on assessing clinical effectiveness rather than the whole assessment of value. So, but there is some kind of push towards having that collaboration in terms of value assessment across Europe. That would reduce any duplication of effort, I would say, that's done. But across Europe, you will find some level of value assessment that's taking place on a national level, and there are national HTA agencies similar to NICE that are available in the different European countries. Within the UK, NICE was established in 1999 and probably at the back of some situations similar to what's currently happening in the USA with difference in access to treatment. So what they have used to call it postcode lotteries. So patients would get different treatments depending on where they live. And there was lack of standardization of care or access to care. And there was the political will actually to start addressing this issue of lack of standardization of access to treatment and the delays in accessing treatment. And that was the push towards establishing NICE, or the National Institute for Health and Care Excellence in the UK. And the current remit of NICE has expanded much beyond what it started to be like. So the value assessment is in terms of technology that NICE looks at. So it started looking at medicines and developing clinical guidelines and looking at the assessment of treatment of pharmaceutical interventions specifically, but then expanded to look at other interventions, so public health as well, social care, and establishing both or developing both clinical guidelines as well as conducting appraisals and informing decisions relating to market access. And I guess the key thing to know is that there is a key difference between how the UK healthcare setting is and healthcare system is designed versus the US. As you know, that the UK is more like National Health Service, and it's a nationally funded health service. But in the UK, it's more of a mix of both public and private insurance. So that there is a difference there that perhaps make it more amenable here in the UK to have national guidance in relation, or national value assessment in relation to new health technologies. But it has been very well versed within the healthcare system now that, for example, with the medicines specifically, NICE recommendations means that funding has to be made available within 3 months for any medication that gets a positive NICE recommendation. And that's at the back of assessing its clinical and cost effectiveness. So the value assessment framework within NICE is based on assessing both the clinical and cost effectiveness, as well as other aspects, although they are not included quantitatively in a metric that's used to assess value, but other aspects come into the equation. So patient preferences, innovation, equity considerations, unmet medical need, and all these aspects are taken into account when the decisions are made by the committees that make these decisions. So I'd say value assessment have been ongoing in Europe for quite some time now, and has made a lot of progress in informing decision making in general.
Thank you so much. I think that was really helpful in terms of painting the picture of the differences in where we are with value assessment in the US and Europe. It really struck me both what Dr. Mattingly was saying about how there's nothing at the national level and it is separate from the government, and we're operating in kind of this black box of value assessment in the United States, where it sounds like there's much more political will and actionability on the European side. You know, Dr. Mattingly was talking about these concepts of value and budget, and then here we hear over in NICE, you know, they have to follow value assessment and fund medications found to be cost effective within 3 months. So thank you for painting that picture of where we are in kind of different stages. And I think that also helps us transition to this second question then of, we are operating in these very different environments. And so they likely contribute unique policy challenges with value assessment. And so I'd actually like to give this to Dr. Dawoud first, because you painted a fairly rosy picture of value assessment in Europe, that it has a role and that they're working towards even more momentum and regulations across Europe. But my guess is there's probably still challenges as well. So do you mind speaking a bit to those?
Yeah, sure. So it definitely isn't without any challenges. So it's clearly this is a way ensuring access to technologies or health technologies that are of the highest value, or that are of acceptable value. And this means that eventually you are replacing other interventions that are of less value. And you can't do this without having some kind of resistance from certain stakeholders that are perhaps are having lobbying power on the political arena. So the problem is that not always these decisions are met with acceptance from all stakeholders. You can't please everyone, and that's what happens with a negative decision, for example, or negative recommendation from NICE. When it happens, you will find it all over the news here, that NICE preventing patients access to care, and that in itself represents pressure on the policy makers, because patient groups have lobbying powers, of course, and those patients who lose out sometime, or they are considered to lose out if they don't have access to these treatments, or to the treatments they consider as important for their health. They already have lobbying powers to influence policy makers, and, for example, their members of parliament. And so it has to be very embedded into value assessment, that you have to be very transparent about your decision making. It's very important to be able to defend the decisions that you are making, to show that you have taken these decisions based on the best available evidence, to be very clear and transparent about how you've consulted and how you have involved a wide range of stakeholders when making these decisions. So I'd say definitely it's not that rosy, and it's been through a lot of iterations, how best to engage stakeholders, how to make the process very transparent and based on clear principles. And specifically for NICE, it has evolved over the years with multiple iterations of how this would work, and methods are continuously updated in order to be able to ensure that we are using the best available methods and in this area. But again, as I said, it's never possible to please every stakeholder in terms of the decisions you are making, and have to be able to defend your position and to ensure that you are making the right decisions.
Thank you. Well, oh yeah, go ahead.
You didn't know if you want me to just jump in, Julie?
Yeah, go ahead, please.
Yes. So in the U.S., gosh, the policy challenges are, it is kind of difficult sometimes to think through how these things happen. But I'm a big fan of drug pricing policy and history. And in the U.S., we've been battling with drug prices and how to regulate drug prices, or how to handle drug prices for well over 60 years, ever since I would say late 50s, early 60s is where there were a lot of pushes to do more on drug pricing. We don't have time to go through all the last 60 years of policy development, but in recent years, we've seen pushes from both the right and left, so Republican and Democratic leaders, looking at drug prices as being something we want to regulate or want to address. And what I think is important, obviously, when that's the case, if legislation were to come up to change the status quo, you're talking about major shifts in markets, major shifts by companies that produce these products, and so it's a big deal, obviously. So challenges that we face here, to give an example, right in the last administration, the policy team had a proposal to limit drug prices, they basically said that they wanted the U.S. to have the lowest price as compared to other countries. So if a drug company was offering a drug in another country at such price, we want that best price. I guess most favored nation type clause as an example. While that means the U.S. isn't doing a value assessment, but we are basing our price off of another country's value assessment. So we're essentially exporting the value assessment. So even if you don't know anything about value assessment, you have to understand that if we were to set the price off of what Canada or the UK or Germany does, it's because they've actually done the math and said, okay, we're going to pay this for this product. Or this is the deal we've negotiated. And so So that's why a lot of us in the health economic space in the US have argued, why don't we just do our own math? You know, like we can do math too. So like, why don't we do it? And so anyway, there's a lot of just interesting components around policy. How do you actually get something through? Now with a new administration, different policy levers, you'll see a lot of, discussion. Well, the most recent one around Alzheimer's disease, that one's brought in other issues just in terms of what's the role of the FDA versus CMS, right? So then understanding, where does the price component, where should it fall? Where does it go? And so we have a lot of challenges here in the US in terms of like the structure of Department of Health and Human Services, where it should fall. I've got plenty of opinions, but I'm sure it'd be interesting as we kind of go through this discussion today is thinking through, as you all are progressing through your graduate program, or we have some faculty on here, graduate students, Pharm.D students, thinking about what role you can play in this, like how might you influence policy? So maybe just understanding some of the basic, like how these things are happening. Sometimes you think that doesn't make any sense, but you have to kind of go back and then look to see what happened, like what was happening at the time that pushed a policy thing forward. So that's why you'll see a lot of stuff around insulin. Insulin prices have steadily gone up for 20 plus years. And it's an easy one to, like, from a political perspective, to say, hey, there's a lot of people who are on insulin, understand insulin, let's focus on that. But obviously insulin is not the only issue, right? So we have a lot of, but sometimes in the US you follow like, what's the big news story, and following that news story will then maybe shift the way the political winds blow, if you will.
Great, thank you. I think those are some substantial challenges to be met on both sides of the ocean. And just kind of building off of what Dr. Mattingly said there, of why don't we do it ourselves here in the United States, and asking the students start thinking about what role they can play, starting to think, well, we need people who have these skills, and we need people who have the training to be able to do these types of assessments and understand the policy implications. So if you don't mind starting to extrapolate on your thoughts on the current education and training that is available in pharmacoeconomics and value assessment.
Great, yeah. So this one's one I'm definitely really passionate about, primarily because, and I shared this as we were planning for the call, I'm very proud of the pharmacy school I attended. I had the wonderful opportunity to get a great clinical education in Pharm.D at the University of Kentucky School of Pharmacy. It's a great school. I happen to be born in Kentucky, so hey, I've won the lottery in terms of having a good school that I could be in state for and all that stuff. So all those things kind of worked itself out. But I had been talking about wanting to get involved in drug pricing value assessment as like a high school student. I'm that weird. I wanted to get involved in these types of debates. And I never had an advisor say you should consider a Ph.D. in economics. It was, I said, well, I'll maybe become a pharmacist and maybe that'll allow me to do some good, and went down that path. The University of Kentucky, as great of a school as it is, they don't have a health economist on staff. They just don't, and they didn't when I was a student, and they still don't. And it's a challenge to, for administrators of schools of pharmacy. We have 140 schools of pharmacy. I'm going to just say that there's probably less than 10 schools that have probably more than one Ph.D. trained health services researcher with a focus in health economics that can be available to teach, conduct research, lead students who are interested in those degrees. And so, a lot of us that go and get a degree in health outcomes, health services research, even so we all kind of align ourselves with either epidemiology, policy research. There's different, but you may only be exposed to a small amount of health economics depending on the place that you go. So I guess to say that is, like, even with as rich of an environment as we have in the US with education, like, I'm so proud of what we're able to do in pharmacy education. It's quite lacking. Like, I think it's significantly lacking. And unless you luck up and happen to get some advice earlier in your career, unfortunately I had some great advisors at Kentucky that when I later oh, sorry, I think my can you still hear me okay? Sorry, microphone did some weird stuff. So just saying that I do think that it's important to, like, consider Yeah, I've lost my train of thought. But basically, I think that it's absolutely lacking, and we have a lot of work to do in that space in terms of figuring out what a pharmacist should know, but also maybe not necessarily what every Pharm.D needs to know, but also like what opportunities do we want to have for our graduate students and our whether they're pursuing a clinical Ph.D. Epi-focused PhD, but they want some exposure to health economics work, and just understanding like what level they need and then how can we provide it so that, because not everyone can go to the 5 to 10 schools that have all those things. So how can we maybe expand that education?
Totally agree with Joey. I guess I think that the issue is that it's not US only. It's really a very international issue in terms of pharmacy education specifically. So the focus on pharmacoeconomics is really lacking and has been for quite a while now, despite the discipline itself becoming more and more widespread and widely used in both during drug development. So even within pharmaceutical companies now, health economics and outcomes research departments are growing all the time. So over the last, I'd say 15 years, there has been a huge growth in terms of HEOR departments in pharmaceutical companies, but it's still pharmacists and pharmacy schools are not catering for these required skills. And also generally making use of value assessment in decision making in healthcare systems in general, it has become more and more widely used, and it's really difficult to see why pharmacy schools are not investing in this area. I think the demand is there, and there is a real need to fill this gap, which is currently filled in some countries by the departments of economics. So economic schools are the ones that are providing these specialist training courses, either especially on postgraduate levels. But if you look at generally at the status of pharmacoeconomics education provision across the world, I think very limited at the moment, and we really need to do more in order to educate the new generation of pharmacists about the use of the economic analysis tools in decision making, and even like in informing clinical decision making. Sometimes it will come down to the clinician who's prescribing to make these decisions, and it needs to be informed by some sort of value assessment one way or another, not necessarily just cost. It takes into account, as I said, as value assessment takes into account clinical and cost effectiveness, ethical, patient preferences. It's a holistic approach to clinical decision making. So it really needs to be more to get more focus in both undergraduate and postgraduate education. And in the UK, I was surprised. I have come to the UK to do my PhD, and I was surprised how lacking pharmacoeconomics, and it still is actually very limited, if any master courses, for example, in UK pharmacy schools. It's all based in either health or economic schools. So we really need to do more in terms of pharmacy education, in terms of focusing on pharmacoeconomics.
Thank you. Yeah, it sounds like there's a lot of opportunities for growth in terms of the educational opportunities and training that we offer. And I think that the schools of pharmacy are doing a great job of preparing future pharmacists for pharmacy practice. And so maybe that leads us into our fourth question, that we're preparing all these students to go out into pharmacy practice and be exceptional clinicians. And so how can we better bridge that gap in practice between the practicing pharmacists out on the front lines who can help us inform value assessment?
I'd say definitely, but as I just mentioned, value assessment is a holistic approach to making decisions about even like caring for an individual patient, as well as for making decisions for cohorts or for patient groups. And it's important that pharmacists start to think within their practice in an outcomes driven way. So if you think of the outcomes that you would like to achieve, this is in itself is a value assessment approach. So you need to optimize your outcomes with that patient by whatever clinical management plan you are implementing in your encounter with the patient. So really pharmacy practice can benefit a lot from value assessment, and equally value assessment can inform our practice. Knowing that, for example, even funding a new role for pharmacists, or funding a new pharmacist to come to work, and for example, here in the UK as a pharmacist prescriber, what you need to make a business case. So you need to show that you are adding value. There is a value added by having a pharmacist prescriber. What is the added value that this pharmacist prescriber will deliver compared to the GP or the physician or the general practitioner, or even nurse prescriber? What is the added value? So we need to think how we can demonstrate value of our practice of pharmacists and how they practice, in order to be able to show that these rules should be funded, and there has to be a business case made for this. So again, pharmacy practice can involve, and value assessment can impact pharmacy practice. It's really about thinking in an outcomes focused and outcomes driven way. And we have managed to show that pharmacy can add value, be it community pharmacists, hospital or ward pharmacists, or clinical pharmacists, and in different settings. So it's an important aspect of our practice.
Yeah, and I'll add, I think about two ways, and one, how can pharmacists in the front line have an impact on value assessment, but also how can value assessment impact how pharmacists practice. The first direction, thinking about how pharmacists on a day-to-day basis can impact what we assess as good value. You just go back and look at every pharmacists for over 30, 40 years or longer now have demonstrated in certain diseases where if you don't have a pharmacist involved in some way, shape, or form, like you're going to have worse adherence, you're going to have worse issues with the right medication being optimized. Like, do we need any more data on diabetes and the role of a pharmacist? Do we need any more data there? Like we have pretty good data that pharmacists being involved early and often in the managed care of the patient is going to improve the overall effectiveness thereby, and thereby should improve the value. But what's I think important on the flip side is that if I do a economic model and publish it in a journal, or ICER or a large organization publishes the results of a value assessment, and they say, drug X is cost effective at $70,000 per quality. So again, no quizzes or anything today if you're not familiar with the cost per quality, whatever but let's just say they call it cost effective. It's really important that pharmacists understand what that report means. And just broadly speaking, without having to dive in and get into the methods, but knowing that it means that at a population level, that on average, that point estimate is meant to be on average for a particular population. Your day-to-day patient care and direct working with a patient, you need, that's where we get into the heterogeneity of the different types of patients we interact with, is that not every drug is right for every patient. And so I think it's important that pharmacists maybe can be informed by seeing what the value assessment is. Oh, this report was that it was cost effective. But then when you dive a little deeper, you see, well, maybe there wasn't a lot of good data for a particular patient group or a different type of group that we need to be a little bit more cautious with, because maybe it's still not cost effective for this population, or maybe it's really cost effective for this other population. So I think that's where, when we're teaching our Pharm.D students to become amazing pharmacists, really just that evidence-based medicine course, or I don't know what you all call it at VCU, you all probably have I think every school has got some type of course like that. Please study that statistics and epi very well, so that you can just generally understand some of those things. If I could go back and tell my younger self a few things, I would say take more statistics, take more of that, in pharmacy school.
That's why we call those classes the hindsight classes.
Never enough for statistics.
Fantastic. Well, we've talked, I think throughout your answers to the last 4 questions, you've talked some already about future directions involving patient voice and bolstering education, improving transparency. But we've got maybe about 4 minutes left until we'd like to have lots of time for questions. So if you have kind of a short answer to what the most innovative trends you think are, and or how you think they inform future directions, I would love to hear your insight there.
Mine's easy. I can, because I'm kind of plugging my own research, is I do think we should be actively engaging patients along the way. I actually had an interview with a food allergy caregiver this morning for another study that hopefully will help feed the value discussion, but without talking directly with people who are experiencing the disease. Like, I don't have a food allergy. How can I really fully grasp and understand everything by just what I read in a journal article? So actually doing some of the qualitative work on the front end, I think, is really important. So I'll leave it there.
I'd flag two, actually. So the first one is using real world data, all the big data and healthcare data that's available out there. We tended, and regulators and HTA agencies so far tended to look at clinical data from randomized controlled trials for medicines specifically. But more and more now we have more data that's collected within everyday practice and real life data. And we are in a stage where we are developing methods to know how to use this real world data in order to inform decision making and value assessment. And actually all ways through the health technologies life cycle approach, if we say, or life cycle. So from development to market, to launch into the market, and then to disinvestment at the end and stopping to use a medication or a new technology. And the second is in terms of where we are going. Actually, it's about multi criteria, or using multiple criteria in making these value assessments. So not only relying on clinical and cost effectiveness measures, but how we can incorporate all elements of value in making our decisions in a more structured way.
That's fantastic. Thank you both. I think at this point, that's a perfect time, because we've got 10 minutes, just over 10 minutes. So we would love to hear from students what questions you have while we have time with these experts.
And do you all want to stop sharing the slides at this point? Maybe it'd be easier to see folks if...
Yeah, very good idea.
Someone has a hand raised, but I can't see who. So whoever it is, go ahead and ask your question.
It's Vasco.
Hi, good morning, everybody. Thank you so much for this very good introduction to value assessment. I have a couple of questions myself, and considering the the audience in the room, I would say like it's 50-50 clinical, or maybe like 60 clinical, 40 pharmacoeconomics folks. There's usually the feeling that I get when we have these discussions is sometimes is that the clinical folks kind of tend to stop paying attention, because the idea is that if I'm working in a clinic in the clinical development process at a pharmaceutical company, I really don't care what happens post approval. And so this is my feeling. This is not necessarily what happens in reality. But considering what Dr. Dawoud was talking about, the codification of value assessment frameworks and the value assessment or the HTA process into legislation, or at least into some form of almost like multinational agreement, how does that potentially influence the entire clinical development process? Does it invert that, like phase 1 through phase 4 type of graph that we usually see in pharmacy school?
Happy to make a start, Joy, if that's okay. So yeah, thanks for the question. It actually the decisions that are made further down the line in terms of market access will inevitably influence what are the innovations that we invest in, or pharmaceutical companies will start to invest in. So if you give positive value signals by approving certain drugs, you will find that more and more of the investment goes in that direction, or that unmet needs or therapeutic area of unmet need. So this is kind of like a feedback cycle, if you like, to influence innovation, to be in the direction of interventions or products or medical products that actually demonstrate value further down the line. And these decisions are even made during the drug development cycle for go, no go decisions. So you can have early modeling. Early economic modeling is actually used to optimize or for the choice of which targets to take through from phase 2 to phase 3. So for phase 2 trials, for example, these can inform early pharmacoeconomic modeling to know whether there's likelihood for some of the various doses that you are testing, for example, to be cost effective further down the line. And you stop developing those or take go no go decisions at these stages. It's happening. It might not be that widely used, but it's actually happening either during the development pathway or even that feedback cycle that I'm indicating in terms of what signals the market is giving and the decision makers are giving to the pharmaceutical companies or the technology developers in general, of which technologies are considered of high value.
Yeah, and so to make sure I can respond as well, maybe a little differently, I keep just thinking about the counterfactual of like what's happening now without the any sort of formal value assessment in the U.S. Manufacturers, or as we're trying to innovate and think of therapies, are we targeting? How do we select? What diseases we invest in? How do we select the areas where we put stuff in? Is it those who speak the loudest? Is it those who have the largest campaign? Do you have to have the right celebrity with the right child that has the disease to get the attention? So I guess, my question is, I don't, maybe the question is back to all of us to think about whether you have a clinical background, economics background, whatever that may be, when we think about policy and discussion, where this value component comes in, is that it'll change the goalpost. Absolutely. Like it absolutely will drive innovation in a different way. It's just, we have to have the debate, is that how we want our goalposts to be changed based on math and estimation of what's providing good value, or other factors, because they are being decided now, right? So it's just whether or not we want to include that. Great question.
Thank you.
Thanks, Osco. And I think I see in the chat here that we've got a question from Tyler asking, from your experiences with recent graduates, both Pharm.D or graduate Ph.D., how well do they do at generating a value proposition for their research or their value as a whole? And how do you recommend students improve upon this?
Sure, I can start here if you'd like. I see a pretty wide variety of students in both Pharm.D and graduate program in terms of different levels of, so we a different, maybe based on their exposures. And then, if some Pharm.D students had more exposure to research in undergrad, or had, some other, or got involved earlier in the Pharm.D program in research, I think that I've been so impressed what I can see some Pharm.D students accomplish before, without doing a PhD. And you're almost like, gosh, you need to go ahead and enroll in the PhD program after this, because you're so, you've got that. And then I see some that like research is just not, it's a challenge. And I work with like our Pharm.D residents as well that are required to do research projects. And they often, I see a very varying levels as well there. Compared to graduate students, I would say Pharm.D students and residents are just not going to have the same level of skills, or maybe the same background on average, compared to the graduate students in terms of like selling their research idea, learning that too. But I mean, honestly, even as faculty, we struggle with that too, right? If you get really good at writing a significance and innovation section, you're going to see that in your grant funding, right? So maybe we need to do more marketing education earlier on, more so than just the science that we learn. So I guess to maybe say that's to try to differentiate. I don't know if hopefully that's answering your question, Tyler. I'm not sure.
Yeah, that's very good. Thank you.
I saw a smile from Dr. Holtford there. The plug for marketing education.
I may have read a few of his papers over the years.
All right, well, we got time for probably one more question if anybody.
So this isn't a question, but well, it kind of is, but it's also a statement relating to pharmacoeconomics. I always tell students, pharmaco is the beginning. It drives everything. It seems to me that I don't look at pharmacoeconomics as being something separate that you don't will worry, but I'm a clinician. I don't have to worry about that. I think pharmacoeconomics is a clinical skill. And I find that the more you know about pharmaceuticals, the better you can do an analysis, understand all the factors associated with an economic analysis, and it makes you a much better clinician too. One of the things I'm going to ask Joey a question that I don't know. I'm guessing they're probably not that different from our program, but is economics integrated in your clinical curriculum at all?
Absolutely, yeah. We have we have it formally in a pharmacoecon, pharmacoepi combined course for the Pharm.D program in their I can't remember it's second or third year. And then I teach a pharmacy management course where it's a little bit more practical, but I do readdress health economics as a pharmacy manager would need to understand it in terms of understanding different components of Medicare, Medicaid, and also I do innovation. I put them in the role of CEO of a pharmaceutical company and have them build SWOT analyses and thinking through like a new product, but articulating the value, but differently, not the same way you think in a health economics sense, but in more of a old MBA business school kind of way, like thinking through it that way, just because I feel like that's an easier way to introduce it.
All right. Well, I'd like to, if nobody has any last minute questions to sneak in our last minute that we
have one more question for Dr. Mattingly, though. First of all, I do like to follow Dr. Mattingly on Twitter. For those who don't know, he's very active and very funny as well. So, but in addition to that, one of the things that I would like to ask him, considering the just the sheer opportunity for future graduates in HEOR, and also as a way to promote HEOR degrees for Pharm.D graduates. What is how you mentioned that in the US, ICER is the agency, essentially the nonprofit agency that sort of conducts HEA in the same fashion that NICE does. How meaningful are these reviews for manufacturers, and how do they actually influence coverage decisions for payers? And what's the opportunity there, considering that ICER is doing this? What is the outlook for a future HEOR graduate in the US?
Thank you. And first, also, if you don't follow Dr. Dawoud during ISPOR, she is the most active Twitter user that you'll ever see in ISPOR. So I can't keep up with her, but I do appreciate. Mine gets a little bit more active during Kentucky basketball and football games, so which again, it was a tough weekend for us. But I just say in terms of HEOR opportunities. So here's where I want to, if I can make a sell to those who maybe are more clinically focused and maybe aren't thinking you want to do an econ focused pathway. It's not meant for you to do everything in the model, like it's important to collaborate and work with other team members. And I love working with clinicians who they work on a daily basis treating patients or really in the literature for cardiovascular disease or HIV, HCV, whatever. And then I handle the economics, right? Or I handle the other components. Like how do we, let's collaborate together. Like let's not expect that every pharmacist should have to do a Markov model in Excel. I don't think that's necessary. So I think it's like, how do we make sure we ask those questions and then maybe connect people the right way. Sometimes it's through, attending a seminar like this, not shutting off your ears when you start hearing something going in a direction you don't really always talk about. Like, how do we connect people? Because I do think that there's probably lots of opportunities for amazing clinicians to get to get active in HEOR in some way, shape, or form. The pathway I typically see for pharmacists who, to be blunt, are already like 200K in debt because of the tuition situation we have in our country. It's difficult for them to make the decision to then pursue a PhD and to take a stipend and go that route for 4 or 5 more years. So many look to see like a postgraduate fellowship, for example. So I see that a lot in the Pharm.D space, where I'll see pharmacists, future Pharm.Ds that start approaching me in their first and second year and I think I see myself in that student. I see myself in that student from years ago thinking, gosh, I would have loved to have done a pharmacoeconomic research project in my second or third year and maybe gone and done a HEOR fellowship at one of the companies or Thomas Jefferson or Rutgers. There's several great postdoc fellowship opportunities as well, other than the PhD. So, but I do think it takes some, that's a common pathway, but those are actually really competitive as well. So it's important. I think, getting Pharm.Ds, when you see students that are interested, show interest, it's great to see if you can get them on a research project or get them involved early on. And then, from there, figure out what type of other credential do they need. Do they need another credential, or could they get working on a team? Because over a period of time, once you start publishing and start doing enough work in the space, people stop looking at your degrees. So, it's more about what have you produced, but sometimes just getting the opportunity is a challenge.
Thank you.
Well, thank you both so much. This has been a very insightful session, and I'll kick it off. Melanie, are there any wrap-up items from the CPPI perspective?
I don't think so. Thank you all so much for being here. Both our panelists and the audience. This recording and slides will be available on the website hopefully later this week. So keep an eye out for that if you want to revisit any of the questions and answers. And yes, thanks again. Have a great rest of your day, everyone.